Okay, thank you, Dr. Ayler, for the introduction. For those new fellows and old second-year fellows that do not know me, I am a ambulatory care staff physician. I'm a primary care provider at the James A. Haley VA Primary Care Annex, and I also happen to be an ID doctor, like you all are aspiring to be. And I was a graduating fellow last year, June 2019. So I was sitting right there where you're sitting. Well, not right there because now we have transitioned to this virtual world, but I was there. Good news, fellowship, it gets easier after fellowship, but bad news, it goes too quickly and you learned so much in fellowship. So try to make the best of it. Okay. So, since my area of interest is HIV primary care, I wanted to do something primary care related. And I kind of was wondering if I should do something related to the pandemic or not. I bet, you guys are overwhelmed sometimes with all this information, but I came across, as a primary care provider, I have come across a lot of vaccine questions from my colleagues at primary care. And also, while I was in the ID clinic for the last 6 months, I've gotten vaccine questions from people there and other subspecialties. And I thought it was kind of a good topic to go over, since there's so many frequently asked questions related to how to handle vaccines during the COVID-19. So as an introduction, right, as healthcare workers or, healthcare professionals, we are considered essential. And we are essential during this pandemic and in a variety of roles, and not just, doctors, but all nurses, pharmacists, lab techs. Every role is important, from the person who collects the sample and interprets it to the person who's looking at research development for COVID-19, to the person who has to wear the PPE and has to manage the samples and take care of the patients, to the persons who are developing a vaccine for COVID-19. And also this little person here, this, not little, he's pretty giant. This big person here represents, our role in terms of vaccinations during COVID-19, in my interpretation. So the CDC website is a great resource for all you, for all of us, actually, during this pandemic. They update it frequently, and they have, and I found this a gem called the Interim Guidance for Routine and Influenza Immunization Services during the COVID-19 pandemic. And basically, it just gives, it's a good read, because it raises awareness to some issues that we're going through in terms of this during the pandemic. So let me see. To vaccinate or not to vaccinate during the COVID-19 pandemic? That is the question. So do we have any opinions from the fellows in terms of, what issues can occur if you don't vaccinate, or if you don't follow through with routine vaccination, versus what issues can occur if you do vaccinate, or you do bring somebody to a clinic setting to vaccinate? Any thoughts? Okay. So
when you're trying to vaccinate, when you get the flu vaccine, they'll always ask you, have you having fevers, chills, and that could kind of confound with, symptoms of COVID as well. So that could maybe slow down uptake of the of other vaccines. And yeah.
Thank you. That's Harish, right?
Yeah.
Thank you for your input. So very good. I have a couple of slides on that coming up. So yes, that's one of the main issues that we're encountering now that the flu vaccine is here, and we'll touch on that in a few. Anything else? Anybody else can think of?
Just bringing them in for a vaccination kind of puts them at risk for contracting other issues in the clinic. It's now that we're rolling into flu season and whatnot, if you're only bringing them in for a vaccine. Exactly.
Thank you, Cody. So that is another issue, right? So as doctors, we're always compelled to look at the risk-benefit analysis. So the risk associated to bringing them into a healthcare setting like a clinic or a congregate setting may potentially expose them, unnecessarily to the COVID-19 versus, the benefit of the vaccine, which is kind of a preventive medicine, that doesn't need to be done right away, that can be deferred. So we'll talk about that in a few as well. Anybody else has any other comments before we proceed to the next slide? Okay. So very good. Thank you guys for your participation. So exactly what we said. So we, as healthcare providers, we want to reduce the transmission of SARS-CoV-2, which is the virus that leads to COVID-19, in vaccination settings. So we have to decide if it is safe for, one, people to come out, leave their home to a vaccination setting and risk of exposure because of that, or we also have to decide if they're already in a healthcare or congregate setting, do we want to keep them there longer in order to get this vaccine up to date? However, right, we also have to balance that with the potential consequences of not vaccinating, right? So vaccines have a purpose. So all those, vaccine preventable diseases may increase. Also, we may be at risk for outbreaks. We also have to consider the burden of other respiratory illnesses that may combine their effect with the COVID and wreak havoc, like the flu. And then we also have to think, if these patients get a vaccine preventable disease or another respiratory illness, that will also lead to a necessary medical visit or hospitalization, which also increases their risk of exposure. So now that the services are ramping up and now that we're starting to reopen, it may be a good idea to try to keep the need for immunization in mind in order to protect these individuals and to protect our community from these possible consequences, okay? So, and then other factors to consider is if the patient has an acute illness that may preclude the vaccination, maybe it's not a good time to vaccinate. You also have to consider the underlying risk factor that person may have to develop a severe vaccine preventable illness. Other factor to consider is the likelihood that a person will return for a vaccination at a later time and the degree of which a vaccine preventable illness is occurring in the community. I think it's too soon to tell for flu, but more to come on that. We'll have to see how bad this year's flu season is. So what should we do about it? So this is a direct message to all the fellows that are doing face-to-face visits or rotating at the ID clinic. I'm not sure. I know that the health department is doing telehealth, but how are you guys doing it now? Are you doing some face-to-face or not at all?
It's mostly telehealth still, but some patients come in, especially if you haven't seen them for a while, you request face-to-face.
Okay, great. So
I was in clinic yesterday. We had about 4 face-to-face and 4 not face-to-face. So about 50% now.
Okay, good. So
50% of a very small number.
Okay, gotcha. So at the beginning, right, when the pandemic hit, we were all kind of 100% telehealth. And at that point, it was easy to say, oh, well, let's defer the immunization to that next face-to-face visit. So now we are at the point that we do have some face-to-face visits, and we need to be cognizant of that when we have that patient there. So I know sometimes clinic gets busy, right, when you're trying to do this hybrid thing of telephone, video, face-to-face, but make a mental note to check that immunizations tab or check that immunization record. And if you have a patient in face-to-face, whether it be a non-HIV, just on our general ID clinic panel, or in your HIV clinic, try to see if there's any way you can optimize that clinic visit and avoid any missed opportunity for vaccination. And then, try to do catch-up as well in that visit. So this is what Harish was talking about earlier. No, wait, I'll get to that in a few. So the big question now is when to defer routine vaccinations. At the beginning, it was the obvious answer. Let's defer them. But now, I know that, and I know I saw an email about this, that we're getting questions from like the hospitalists about when should they get certain vaccines, that they're there, should they get it, and also about if the patient had COVID or had suspected or confirmed or was exposed and they want a vaccine, should we bring them in or not? So the interim guidance I was talking to you guys about earlier breaks it down in terms of a symptomatic person who have tested positive for SARS-CoV-2. So these patients, you should defer a routine vaccination visit for at least 10 days from the positive result. And those are the ones who, they just have to complete that isolation period. And then the guidance on symptomatic patients is for those who've been confirmed with COVID-19 or suspected, then you should defer until sorry about that. I just realized that this mouse is going crazy. Sorry about, okay, there. So you should defer the vaccine until all the criteria for discontinuation of isolation has been met. And that means all of them. At least 10 days after their symptoms have commenced, at least 24 hours without any fever, without the use of fever-reducing medication, improvement overall of their COVID-19 symptoms, and that the person is no longer moderately or severely ill, because if you give them a vaccine while they're severely ill, you may complicate their clinical presentation. And then for those who have been exposed to a person with known COVID-19, then they should at least wait out the 14-day quarantine period before seeking any outpatient care solely for a vaccine. And that's basically because we want to also avoid exposing the healthcare personnel and other patients in that setting. Okay, so now we're going to talk about what Harish was brought up earlier. So considerations for flu vaccine during the COVID-19 pandemic, frequently asked questions. That interim guidance also provides some guidance on the flu vaccine. And then the main question you may get from patients is, should I even get vaccinated during the COVID-19 pandemic? So who should get vaccinated? Well, almost everybody. I mean, as long as you're more than 6 months old, you don't have a major contraindication to it, and there's an indication for you to get it, everybody should get their annual flu vaccine. But if, let's say there's a shortage, who should we prioritize? Well, essential workers, the healthcare personnel, also those persons at increased risk for severe COVID, those that are in a post-acute or long-term care facility, and those adults who are more than 65 years old, and those persons that are at high risk for influenza complications, and they particularly list children between the ages of 6 months and 5 years old, especially if they have a neurologic condition, pregnant women, and adults more than 65 years old. So we work at the VA. Most of us do, or we rotate, and most of our population is above 65 years old. So the first thing you find when you go into the VA website is this, when you open a new tab in Chrome. So we can get vaccinated at the mobile outreach unit, as well as I think they're allowing patients there, if I'm not mistaken. We can vaccinate the patients at the clinics, at the subspecialty clinics, and also at the CBOX, and also at the primary care clinics. So let's try to push for that. In terms of what flu, I've gotten a lot of questions about what flu vaccines we have available this season at the VA. I just want you guys to know that it's very good to get familiar with the nomenclature, so that when you go to the immunizations tab, you can kind of find out what vaccine they received. So basically, we have inactivated, recombinant live influenza vaccines. You can have a trivalent or a quadrivalent available, and you can also have adjuvanted, cell culture, high dose, or standard dose. So it's important to understand that the flu vaccine is not like a one formulation, one fits all kind of thing. It's kind of, there's different brand names and there's different formulations. So be keen to that detail when you are assessing a patient and deciding what vaccine to give them or what vaccine they already got. So specific guidance for adults 65 years old, there is data supporting greater benefit of the high dose, the Fluzone trivalent, the recombinant flu block, or the adjuvanted, which was the fluad trivalent, relative to the standard unadjuvanted inactivated influenza vaccines in this age group. The most well-studied of them, the high-dose inactivated trivalent one, was more effective than a standard dose in a large 2-season randomized control trial. And then this season, the high-dose trivalent has been replaced by the high-dose quadrivalent. We also have an adjuvanted quadrivalent available this flu season. And I'm not talking about the VA, I'm talking, general updates. And but there is limited data comparing these to the standard dose. The main point is that you should not do, if you have a patient in the clinic and you are out of a formulation of a certain vaccine, but you have another product that is just as appropriate, use the one that is available. You can use, the standard dose or the recombinant, because the main point is get them vaccinated. Because if you delay their visit in order to find a particular product, you may have missed your opportunity, missed your window to get them vaccinated, and you don't know if they're going to come back at a later time. And that's out on the CDC website. So VA-specific flu vaccine updates, and feel free to correct me if I'm wrong. I understand that we both have both quadrivalent standard and high-dose vaccines available. The brand of the standard dose vaccine may vary depending on location. I think last year we had the fluad, but per my discussions with the clinical pharmacists, we don't have this one this season. We got the Fluzone and the Fluorix. So these are the ones that I understand we have available at the PACs and as well as the ID clinic. And then unless there's been an update that I'm not aware of, and then the patient doesn't have to come to the clinic at the VA or their primary care to get the flu vaccine. They can get it through community care. They can go to the CVS without a referral or appointment. They just have to show their ID. And it shouldn't incur any cost or copay if they've been receiving care through the VA or through community care provider. And I think they can also go to Publix or, there's options for these vets to get their flu vaccine. And then this is what Harish was talking about, is what to expect after the flu vaccine administration. So for the flu vaccine, you can expect local injection site reactions, redness, pain, swelling, but you can also expect some systemic reaction, fever, chills, headaches, body ache, which looks like a flu-like syndrome and may cause the recipient to think, oh, do I have COVID? But general guidance is that usually symptoms related to a systemic reaction will resolve within 72 hours after the vaccination, and the patient shouldn't have respiratory symptoms associated to the vaccine. So you should tell the patient, stay home until you're fever-free for 24 hours without the use of antipyretics, just to ensure, unnecessarily exposing anybody if they did have COVID. And then things that will make you think of COVID-19 and maybe that patient should go seek medical attention or consult their healthcare provider is fever lasting for more than 72 hours after the vaccine, and then new onset of respiratory symptoms, shortness of breath, cough. This is what the guidance suggests. We all know that COVID is, has a myriad of presentations. So as well, clinical judgment will play a large role in this. So this is the email I was referring to. Hospitalists asking should they get the flu vaccine if they had COVID-19, that were hospitalized or admitted for COVID-19 and now they're at discharge. So for those who have acute illness with suspected or confirmed COVID, you should delay the vaccine until the patient is no longer acutely ill. And if it is delayed, then you should remind them to come back. But, the interim guidance also suggests if they're okay at discharge, they're no longer acutely ill, go for it. Because it may, you have them there and it may represent a missed opportunity. And then if they come back with the flu, later, then it's also an issue. Certain concerns with this is that, COVID-19 treatment means immunosuppression in a sense, because they may get steroids, they may get TOCI, and then the concern is that because they were exposed to this immunosuppression, they may have an increased risk for severe flu if they didn't get vaccinated, for example. But also, there is concern that these medications may diminish the immune response and the uptake to the flu vaccine. But still, too soon to tell. And also, the optimal timing for flu vaccine in these patients is yet to be determined. There is no specific guidance on that. So watch out for that. And just some other specific guidance. Those who are caregivers and contacts of high-risk persons, if they do get the live, then they're taking care of somebody who's immunosuppressed, and they should at least avoid providing care for 7 days, and then or preferably they should get the inactivated or recombinant. And then this is important as well, because we in our clinics, ID clinic as well as HIV clinics, we have immunocompromised hosts, so avoid giving the live to the immunocompromised person, do the inactivated and recombinant. And then I know last year we were, when we had the flu ad, I know we made a point for giving the high dose to the HIV patients. I'm not sure if that's still kind of the case, and anybody can chime in if they know the answer to that. But things to consider. And then this is basic. I liked the CDC website guidance on, because they have it by age on the schedules, the vaccination schedules. They have it by age, and they also have it by indication. And this is particularly important in our clinical practice to keep in mind. The yellow means that the vaccine is recommended. The red means that it's not recommended. The gray is the gray zone. It's pretty self-explanatory. And the purple is optional. So in those patients that we're seeing at the HIV clinic, I know at the VA clinic we're still doing HIV telehealth, but things to keep in mind is that they should get their flu, their Tdap, the MMR, varicella, if they don't have immunity, and they're live vaccines, but if their CD4 is above 200 and they need it, you can do it. There's a gray zone for the shingles vaccine. HPV, it says 26 years here, but remember that it has been extended to 45. Pneumococcal vaccine as well is indicated, as well as a hepatitis and the meningitis. And you can optionally give Men B as well as H flu if they have an indication such as asplenia, and they're immunocompromised, so they do. So a lot of people can get them as well. So, what is the impact of the COVID-19 pandemic on vaccination schedules? What have you guys as fellows bumped into? Anything? Any anecdotes or anything pertinent in your individual HIV continuity clinic?
Well, in an HIV continuity clinic, I didn't have. It was more difficult to get patients into in-person visits to get the vaccines than
exactly.
Exactly. That was more difficult part.
And that's something that we are still dealing with. I feel like there's an appropriate GIF of how I felt with this issue, and COVID-19 pandemic has bent my space and my time, right? And our space and our time. So basically, the timing of vaccines got off, whether to initiate, you know that a person needs a vaccine and you haven't been able to initiate it, or whether you started a series and then you got caught in the middle of it. And also the spacing is like you don't have a place to give the vaccine because we've been forced to kind of shut down a little bit and diminish exposure. So I already told you guys this. What I want you to take away from this is that there is no time like the present. If you have a patient face-to-face, keep that in mind. It's an opportunity to vaccinate. And immunizations best practices. I rotated at the HIV clinic at the health department, and I learned a lot about how to give vaccines and employ best practices to our HIV patients who need to get up to date in some of the vaccines. So strategies for catching up. Remember, you can always do some simultaneous administration. There's combination vaccines, and it's also important to keep the minimum and maximum intervals of these doses in mind when you are giving simultaneous vaccines and when you're, giving follow-up visits for vaccines. So simultaneous administration basically is when you administer one vaccine, more than one vaccine on the same clinic day at different anatomic sites, and they're not combined in the same syringe. When you're working with a nurse, I try to ask them to document what vaccine they gave in what arm, because let's say they got a flu in one of them and the pneumonia in the other, and nobody documented which arm it was, and the patient was flu vaccine hesitant, and you had to move mountains to convince them, and then they develop a local site reaction, and they're like, aha, it was the flu vaccine, and then it might have been the pneumonia vaccine. So I try to make them document that so that we can know especially what vaccine caused a local site reaction, so that the patient, to clarify with the patient. And then this is a great way to vaccinate those people that need an accelerated schedule, either because they need rapid protection because they're going to travel, which now that with the COVID-19 pandemic, I don't know how much traveling you want to encourage, but also it's great for those who are behind schedule. And the rationale is that the seroconversion rates and the adverse reaction rates are similar to those observed when the vaccines are given separately. So, there's not increased risk of adverse reactions of giving together, and they sort of convert just fine as well. So general rules, you can use the live and an inactivated vaccines simultaneously. You can do live vaccines together as well, like MMR and varicella, or live attenuated with MMR or varicella if you need to. The important thing is that if they need a second dose, you have to wait 4 weeks. They need a second dose of the live vaccine. The grace period, which we'll talk about in a few, does not apply. You can do inactivated flu with pneumonia. You could do it with any of the two, Prevnar and Pneumovax. You could do it with Tdap. That's the one that they specifically mentioned on this website. But if you want to simultaneously administer, other vaccines, like, I've done with hepatitis B, not just with yellow fever. I've done it with different vaccines and haven't had an issue. So if there isn't a clear-cut exception to simultaneous administrations, there's very few, just go for it. I did a good practice with Dr. Morano when I was rotating with her, that we would just put down 0, 1, 2, or 6 months and see what vaccines the patient needed, and try to figure out that way which one they were going to get today and which one they were going to get in 2 months or a month from now, based on the vaccine schedule for each. And that way you can have a plan going forward. General exceptions is that you shouldn't use the Menactra, the quadrivalent meningococcal conjugate, with the pneumococcal conjugate with Prevnar. You should at least do the Prevnar first and then the Menactra. Food for thought. Was keen on this. And then if you're going to receive both pneumonia vaccines, as you guys know, you've probably done it in the clinic already. You do the Prevnar first, and then you have to wait at least 8 weeks prior to doing the Pneumovax. And if they did the Pneumovax first, then you wait like a year to do the Prevnar. Combination vaccines. The classic example of this that we use in clinical practice all the time is the Twinrix. And what I usually do is I get the baseline serology if I'm able to, right? If they have labs, I try to get it. And we always get the Hep A IgG, the core surface antigen, surface antibody, which with Hep C, right? Because we want to rule out co-infection. And that helps me decide if they need Hep A, they need Hep B, or they need both, or they need none. So always make it a good exercise to check, their vaccine immune status to hepatitis, and this will really help you guide your decision in terms of that. And then minimal and maximal intervals is basically, there is a minimal interval you should wait before administering dose 2 or dose 3 in a series, because if you do it too close together, it could lead to a suboptimal immune response. But if you do it a few days earlier than when their next dose is due, it shouldn't have a substantial negative effect. And this has happened to me in the clinic. I mean, the patient gets a dose for, let's say, Shingrix 2 months ago, and they come into the clinic for an unrelated reason, and it's like 2 or 3 days till they're due for their next Shingrix. I've allowed it. I've authorized it because of the grace period. And basically, the grace period is if you administer the vaccine less than 4 days before they're due, that dose is considered valid, okay? And day 1 being the day before their vaccine is due. There are certain exceptions to the grace period, so always look into that. And then also, the main issue we're probably going to run into during the pandemic is that you're going to have the interval between doses that are longer than recommended. Right now, I have a lot of patients that I started the Shingrix series sometime before the pandemic, and now 6 months in, they still haven't gotten their second one. Today, we got one. For example, I reviewed his chart that he got the vaccine in March, and he got his second dose now in October, which is 7 months later. And I still gave it to him because even this doesn't typically reduce final antibody concentrations, one, and the only issue is that you might not attain full protection until you get the total number of doses that you need. So, go ahead and make a case for, vaccinating them, even if they're lapsed, because you may still confer protection. And not in all cases you need to restart a series or add extra doses or add a toxoid. It's very few exceptions. So keep this in mind as well. So basically, when you Google Catchup immunization schedule for adults, this is what comes out. I like the Catchup immunization schedule for children. It's very clear cut, but for adults, I feel like you have to really go into the tabs and look and look and look to find your answer. So I found this table in the Minnesota Health Department, which is maybe a good resource because it says the vaccine, when the schedule is, the minimum amount of time that you have between dose 1 and 2, and this may help you gauge, if you can safely administer that vaccine if you have that person a face-to-face visit. Up-to-date is also has the same information, but it's wordy. So for you guys who are visual and like to see it like that, it may be a good way to organize your thoughts. And then plenty of resources to where you can find, how to best vaccinate our, HIV immunocompromised hosts up to date. The IDSA has these guidelines. The CDC also has these guidelines. Stanford has some scattered information, New England. As a fellow, recently graduated fellow who took her board in December, this is for the second-year fellows, try to figure this out because we had a lot. I remember Nate, I don't know if you guys know Nate, he was traumatized by these questions, and he's our what-if fellow. So the discussion after our boards was really lengthy because we had a lot of bizarre scenarios about pregnant women who were exposed to somebody who got a live vaccine, stuff, crazy stuff. So try to read this before you take the board and kind of reach a general consensus to what you should do with certain vaccines, because there's going to be a lot of bizarre scenarios with vaccination and immunocompromised and their caregivers and their contacts. So you've been warned, okay? And then last but not least, I'm not going to hone into a lot of this because I'm running out of time, but there is a COVID-19 vaccine pipeline. I wasn't unable to attend ID Week last week, but I bet they talked about this. And just if you look up COVID-19 prevention, I'm not going to go into detail, but in your Stanford, you can just get a general overview of, some trials that are currently underway and the vaccine products that they're using for these vaccines. And then here's like a table of some, some of the trials and what type they are and where you can look it up. So if you guys want to learn more about that, it's a great resource. The only thing I want to mention here is that I've spoken to Dr. Tony, and he's informed me that yes, we will be the VA will be participating in a COVID vaccine trial, and the trial we're going to do is the Janssen. I think there was initial meetings about this. I don't have the details, but if you guys want to know more, Dr. Tonio is always open door, and he's always willing to teach and explain. So, so keep that in mind. And my references, the CDC website is our go-to, up to date, the Sanford. And if you have any questions or comments, go for it. And I hope you enjoyed the presentation.